Hi, everyone. Thank you so much for joining us today on this Wednesday, June 14th, for our Age-Friendly Geriatrics Teleecho series. Today's session is going to be focusing on delirium prevention and management. We're going to be following our same agenda with just quick welcome introductions and announcements, followed by our didactic, and then following with our closing and reminders. You all know the house rules. You are all muted upon entry. So if you do have a question at any time, feel free to unmute yourself or type that in the chat. It's always helpful if you introduce yourself in advance so you know who you are. Thank you so much. As you all know, we are CME accredited, and our main objective is to educate community and rural healthcare providers in age-friendly geriatric patient care. We are a 1 AMA PRA Category 1 credit for CMEs today, and the California Board of Registered Nursing does recognize CME credits as transferable for their members. So nurses may receive CEUs after submitting their UCI attendance certificate directly to their board. So within a few weeks, you usually receive your certificate via the email that you fill out in your CME forms. This project is supported by the Health Resources and Services Administration, and this information or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. As you all know, we always love for you all to introduce yourself. We have quite a few people on the line, so if you can just introduce yourself via the chat function, we'd love to know your name, your role, your site, and your location. This also helps us with attendance as well if you do decide you want CME credits. So we'll go ahead and introduce ourselves as you go ahead and type in the chat. I'll get started with our hub team. My name is Nika Seville. I am the project director for the GWEP program here at UCI in Orange County, California. And I'll have Dr. Sagal introduce herself today.
Thank you, Nika. I'm Sonia Sagal. I'm a clinical professor in the Department of Medicine here at UC Irvine and in the Division of Geriatric Medicine and Gerontology. My practice site is in Orange at the Senior Health Center, and it's my pleasure to be here today. Welcome.
Thank you, Dr. Sagal. And Dr. Pereira is also on our hub team, and she's going to be presenting the didactic today. Dr. Pereira, do you want to introduce yourself?
Yeah, hi everybody. Thank you for joining us today. And I'm excited to talk about delirium.
Thank you, Dr. Pereira. And PA George.
Hi, I'm Valerie George. I'm a physician assistant and I work at the Senior Health Center Geriatrics in Orange. And glad that you could all join us today and interested in seeing Dr. Pereira's topic today. Thanks.
Thank you all, and thank you for putting it in the chat. I see Camille, Jolie, I see Karen Forrest from Colorado, Kevin, some people from Meals on Wheels joining us today. Again, thank you so much for being here today. At the end of today's session, we will show you the QR codes for the CME forms that you need to fill out and the evaluation, and those will also be sent via email as well with these slides. So without further ado, we'll go ahead and get started, and I'll hand it over to Dr. Pereira.
Thank you, Nika. Good afternoon, everybody. So let's talk about delirium with a focus on prevention and management today. Next slide. So, excuse me. So I'll start with an introduction to delirium, discuss its definition, the types of delirium, and the impact delirium has on our patients, and also talk about complications of delirium and kind of focus on why it's so important to manage delirium and prevent delirium, and talk about its management and prevention lastly. Thank you. Next slide. So the DSM-5 criteria defines delirium as a disorder of attention and awareness that develops acutely and tends to fluctuate over a period of 24 hours. There can be additional deficits in memory, language, orientation, your visuospatial ability, and your perception. And this disturbance should not be better explained by another neurocognitive disorder like dementia, depression. And it should not occur in a state of severely reduced level of arousal, like if your patient is in coma. The history, the physical exam, and the laboratory findings should be able to point to a direct physiological consequence of another medical condition, like sepsis due to pneumonia or urinary tract infection, or hospitalization, maybe hypoxia. Next slide. So delirium has been described in medical literature for about 2000 years. I was surprised myself when I found that, and it has been referred to by many different names, like acute confusional state, acute mental status change, toxic or metabolic encephalopathy. Delirium being common and being in our medical literature for this long, it's surprising that only about 12 to 35% of all cases are recognized in routine care. And a diagnosis can be missed between 50 to 75% of the time. Next slide. There are different types of delirium. Hyperactive delirium accounts for about 75% of all cases of delirium, and presentations may include decreased responsiveness, lethargy, flat affect. It is the most common type, but it is also the most common type to be missed and not recognized as delirium. Hyperactive delirium gets our attention a little bit more, probably because of its symptoms of agitation, restlessness, pulling your IV lines that you may have worked really hard to put in. So it probably catches the medical team's attention more than a hyperactive delirium. And then there's this mixed type where it can fluctuate between hyperactive and hyperactive delirium. Next slide. Let's talk about the impact of delirium. So delirium is common. In general, in the general population, about 25% of patients who are in the hospital, in the medical wards, can have delirium, 50% are in the surgical wards, and 75% in intensive care units. So wherever you are practicing, whether it's in medical wards, in surgical units, inpatient, you will see patients who have delirium, and it may even be in an outpatient clinic or in a nursing home. Next slide. In our elderly patients, about 1/3 of those who get admitted to a medical unit can have delirium. And it is found that about 50% of that 1/3 of the admissions have delirium when they actually get admitted. And the rest of the 50% develop delirium while they're in the hospital. In the emergency department, 10 to 15 of the percent of the patients who are admitted to the emergency department can have delirium. 15% of new admissions to a skilled nursing facility can have delirium. And in the community, in a primary care practice, about 1 to 2 of your patients may have a presentation of delirium. And for those who are involved in end-of-life care, delirium can be as high as 85%. Next slide. And delirium is associated with poor patient outcome. We talk about the 4 Ds, death. It has been noted that delirium, just by having a patient, just by having delirium, can increase mortality risk by 2-fold. It can cause disability, where it may impair mobility, independent function, and deterioration whether it's physical or it can be cognitive as well. There is a discussion that delirium may be an event that exposes an underlying cognitive deficit. Like you may be having cognitive decline, but then you have an acute event and the onset of delirium, and then you do develop more obvious signs of memory loss and dementia. But it is also thought that delirium itself could be the trigger for the onset of cognitive decline. And as we know, it also causes longer hospital stays, discharge difficulties, finding placements for patients, and also discharging patients home, as it may make it more difficult to care for these patients. Next slide. More and more studies have shown that delirium, it's not just during the hospitalization or it's not just specific to that hospitalization or during that time of acute illness. It has been recognized that once it starts, it may go on for weeks to even months, and it could be as long as 6 months. If you look at this data, so at discharge, about 45% of our patients may have delirium, and at 1 month, 33%, at 3 months, 26%, and at 6 months, 21%. Studies do say that after 6 months, if any existing deficits are still present, to consider a diagnosis of cognitive decline. And we do have the ability to predict in some way those patients who are at risk of a more prolonged course. The risk factors that have been identified are advanced age, pre-existing dementia or having multiple comorbidities, already existing functional impairment, the severity of delirium, and use of restraints has been associated with a prolonged course of delirium. Next slide. And how do we diagnose delirium? Next slide. So to diagnose delirium, we need to fulfill a few criteria. We have to note an acute change in mental status, as I mentioned, some of the features of delirium, like being hyperactive or hyperactive, not interacting in the patient's usual way of interaction, and also need to note a fluctuating course. Inattention can be checked by asking patient a simple question like name the days of the week backwards. So if patient has difficulty to give you that answer, it may be fulfilling the criteria for inattention. Once you have this acute change in mental status and fluctuating course and inattention, and you also need a third criteria, which either could be disorganized thinking or altered level of consciousness. Disorganized thinking could be this patient may not be answering your questions correctly, maybe skipping from one topic to the next, not able to focus. And then altered level of consciousness could be sleeping more than usual or not sleeping at all and being hypervigilant or hyperactive. Next slide. And delirium can be diagnosed with your history and physical examination, but it has been found that using assessment tools like the confusion assessment method has improved diagnosis. And over the years, different versions of CAM has come up, and it is used, different versions are used in different care settings. Like CAM ICU is more for ICU patients, and then in the emergency room, BCAM is used. Again, in our busy clinical practice, it's always good to have brief tools. So you can use something like UBCAM. Next slide. So the ultra brief confusion assessment method has 4 steps. The first one is to evaluate for depressed level of consciousness. If the patient is not arousable, you do not proceed with the rest of the assessment. You can diagnose the patient as being in stupor or coma. But if not, you can move on to step 2 and again, test the patient if the patient has difficulty with attention, like name the days of the week backwards or months of the year backwards. If the patient gets both of them correct, then you don't have to move on to the rest of the assessment. You don't diagnose the patient with delirium. But if they do, you do move on to step 3. And in step 3, you look at the 4 features we talked about, but you don't have to do each and every step that's listed. Once you find a positive feature in one of the features that we look into, you can move on to the next step. So feature 1 would be the history reports from the medical staff and your observation on changes in thinking process, attention, patient being disoriented, having hallucinations or confusion. And then you could do your test of attention, and you don't have to repeat it if you've already done it. And then move on to step 3, where you could ask the patient, where you could check the patient for orientation by asking the day, the year, the location, and observe speech. If there's illogical speech, if the patient goes off in different directions, not sticking to one topic, that could count as a positive sign. And then next we move on to feature 4, where altered level of consciousness, like sleeping more or hypervigilant. So if you have features 1 and 2, and either 3 or 4, you diagnose the patient as having delirium. Next slide. So when we talk about delirium and its prevention, it's always important to know who are more at risk. Next slide. Predisposing factors. So there's predisposing factors and precipitating factors. Patients who have 1 or more of predisposing factors have a higher chance of developing delirium. And these are advanced stage, pre-existing dementia, pre-existing functional impairment, and multiple medical problems. You may recall from my earlier slide that these are some of the risk factors for prolonged delirium as well. So most studies support that these 4 factors are quite significant predisposing factors. Some studies have pointed to male gender, vision or hearing impairment, alcohol abuse, history of alcohol abuse, and presence of depression as risk factors for delirium as well. And then we have the precipitating factors. So it could be an acute event, like if you start a patient on a new medication, which may be sedating or has anticholinergic properties. It could be a surgery, uncontrolled pain, low hematocrit, like onset of anemia, prolonged bed rest, indwelling devices, and physical restraints could be a precipitating factor for delirium. Next slide. So the greater the number of predisposing factors, lower the severity and number of precipitating factors to cause delirium. So it doesn't take much for these patients who are at high risk to develop delirium. Next slide. Here's some data on post-operative delirium in elderly patients. As you can see, if someone doesn't have any risk factors and you're over the ages of 70, you may have a 2% risk of developing delirium. If you have 1 or 2 factors, that risk could increase to about 10%, 3 or more, it could be high as 50%. Next slide. And we'll talk about management of delirium. Next slide. So always starts with history, physical exam, and laboratory testing. Most treatable causes of delirium are outside of the brain. So it is an outside concern like medications, infections that causes delirium. So if we are thinking about reversing or managing delirium, we need to take out the precipitating cause. So we always need to look for the cause for delirium to manage delirium successfully. And keep in mind that there may be more than one cause. So even if you find one possible cause for delirium, do not stop there. Keep looking at all the risk factors and all the precipitating causes that could cause delirium. Next slide. When looking at what is the cause for delirium, again, we go back to our history, physical exam, and clinical diagnostic testing. So for history, look into the presenting symptoms. Did the patient come with fever, shortness of breath, or pain? And then look into their medical history. Are there any current medications that could affect their cognition and concentration adversely? Was a new medication started? Is the patient taking any over-the-counter medications or any herbal supplements that may trigger delirium? Also, pay attention to their history of substance abuse. Has there been a history of use, or is this more of a withdrawal that has precipitated a delirium? And when it comes to the physical exam, vital signs are vital. And then it also includes the oxygen saturation, because we do recognize that a low oxygen hypoxia is a trigger for delirium. And do a good mental status exam and a routine physical exam that includes a neurological exam. And when it comes to testing, our basic testing includes a complete blood count, electrolytes, kidney function, and depending on the presentation, you can decide if you need to do urine analysis, urine toxicology, blood alcohol or drug levels, ABG, chest X-ray, EKG, or any brain imaging. Next slide. Managing delirium can be categorized into 4 main components. The first is to identify and treat reversible causes and maintain behavioral control and anticipate and prevent further complications and restore function in patients as soon as it's safe to do so. Next slide. Looking at reversible causes, the good news is we can use a mnemonic called Delirium to really have our list and kind of make sure we don't miss any of the reversible causes. And as I mentioned, even if you find one, we have to look into all the other possible reversible causes as well. So we start with D for drugs. So high-risk medications like anticholinergics, opioids, benzodiazepines, H2 blockers, antipsychotic medications, and any over-the-counter medications like Benadryl or Tylenol PM should be looked into. And any new medication, if you notice a new medication was started, even if it's not on the high risk list of medications, you do have to pay attention and see its possible effects. Look into electrolyte disturbances like dehydration, sodium levels, and also lack of drugs. Maybe it's a withdrawal or poor pain control that has triggered the delirium. Ruling out infection is always important. And also think about reduced sensory input. Is the patient who's admitted to the hospital is the patient not using his or her hearing aids or eyeglasses? So if so, it's easily replaceable, and we could prevent even an onset of delirium. And then, of course, the intracranial, like stroke, tumor, and infection should be looked into. And again, your history and physical exam will help with that, along with your diagnostic testing. Make sure your patients are not having constipation or urinary retention, and you can intervene early on that. And then also other cardiac or pulmonary problems like myocardial infarction, heart failure, hypoxia, COPD exacerbation. Next slide. Moving on to our second section of managing delirium, maintaining behavioral control. So in the hospital or in a nursing home, you can have these patients placed in a room near the nursing station, so they could have more interactions and make sure the patient is safe. And provide frequent orientation. You could use clocks, calendars, window view to help with orientation to the time of the day. And also whenever healthcare personnel comes in, they could introduce themselves and help with the reorientation process. And you could also counsel the family members who are visiting and explain what's going on with their loved ones, and encourage them to also reorient patients, and even frequently visiting their loved one can help with the reorientation of the patient. And as I mentioned before, providing eyeglasses and hearing aids will also help. Next slide. So physical restraints. I did mention that it could be a potential precipitating factor, and also a factor associated with prolonged delirium. And the other part to using physical restraints is it can cause physical injury on the patient if they keep pulling while they're restrained. So in general, we discourage use in medical and surgical wards, and we encourage the staff to reorient, distract, and find a non-pharmacological way to help patients calm down and oriented. The only time that we may consider using restraints is in an ICU setting, especially or if there's a risk that the patient may pull out a very, any devices that have been inserted. If there is a risk, you may consider it, but always reassess the need for it and remove it as soon as you can remove it. Next slide. Talking about medications to help manage some of the behaviors. So keep in mind, though, medications can cause side effects. It may cause more confusion, loss of mobility. But if we really do need to use it, if there is a risk of injury to the patient or family members, if they're at home, or the staff, we may use the lowest effective dose for the shortest time that we need to use it. So presence of hallucinations or delusions that are frightening, that we cannot reassure the patient verbally, may be considered as a situation where you can use medications to help with delirium and its behaviors. And as I mentioned, if it's dangerous to the patient or others. Next slide. So here is a list. I actually got this from the geriatric review syllabus. So it talks about what medications are considered as first line. So we have the second generation antipsychotics that we use as first line medications. So we could use medications like risperidone or olanzapine or quetiapine as our first choice. But it really depends on the patient's medical history. If you look at this chart, so quetiapine can cause more sedation, but less extrapyramidal symptoms, whereas olanzapine and risperidone has a higher extrapyramidal symptoms, but it may be less sedating. So of course, if your patient has like Parkinson's disease, you would prefer to use something like quetiapine if you really need to. Next slide. And here are the second line treatment options. We have haloperidol and lorazepam. So in general, you try to use the second generation because it is considered safer. The only time a benzodiazepine can be used over a second generation antipsychotic is psychotic medication is that if it's related to alcohol withdrawal or if there's a history of neuroleptic malignant syndrome. But there are black box warnings for all of these medications. For example, for second generation antipsychotics, there's an increased risk of strokes and mortality in patients with dementia. And first generation antipsychotics have been known to cause increased mortality among patients with dementia as well. Next slide. Moving on to anticipate and prevent or manage complications. So the problems that occur when patients have delirium is reduced mobility, an increased risk of falls, urinary incontinence, sleep disturbance, and feeding disorders. As you can see, this may cause a vicious cycle of one leading to the other, like impaired mobility and can cause pressure ulcers. And if you have feeding disorders, it may cause malnutrition, which may cause poor wound healing. So it could just become a vicious cycle. So we do have to intervene and prevent some of these complications. So having a plan in the medical ward or in your nursing home to have these patients have a scheduled toileting program. Starting physical therapy early, avoid restraints, mobilize with assistance whenever it's possible, whenever it's safe. Repositioning the patient and mobilizing early will help prevent pressure ulcers. And then sleep disturbance, so maintaining good sleep hygiene. Patients being active during the day will sleep better at night. And you do want to think about their environment, minimize, the alarm bells, a lot of lights and getting vitals close to bed around bedtime. If we could schedule the time of these interventions and reduce noise, perhaps our patients will sleep better and less delirium will occur. And then when it comes to feeding, paying attention to their nutrition, and sometimes your patients may need a one-on-one assistance when it comes to feeding. So having the staff evaluate and then providing this additional assistance will also help. Next slide. And again, restoring function kind of, sums up some of the things we talked about, like providing a peaceful environment, reducing clutter and noise, having exposure to adequate light during the day, and reorienting patients, educating family about delirium, and, having them as part of your team to help these patients restore their original function. It's important to educate the family members about delirium, its causes, its reversibility, and then also to discuss with them that, the patient can start doing their activities of daily living, like toileting, going to the bathroom, when they are able to, rather than unnecessarily restricting them. So as long as, it's safe to do so, the patient should be allowed to carry on their activities of daily living as much as they can. Next slide. So let's talk about how to prevent delirium. Prevention is always better than cure. So let's talk about some of the data that we have to try and help prevent delirium from the start. So studies have shown that in an acute hospital setting, a multi-component non-pharmacological interventions by interdisciplinary teams have reduced the risk of delirium. And the Hospital Elder Life program is an example. And this program had 6 interventions where it focused on recognizing patients with cognitive impairment, sleep deprivation, and immobility, visual impairment, hearing impairment, and dehydration. And it has shown that it has reduced the onset of delirium. And there is also data to show that proactive geriatric medicine consultation for patients undergoing hip surgery, that it has reduced the onset of delirium as well. Ramelteon is a melatonin like medication. It works on the melatonin receptors, and studies have shown that Ramelteon has reduced risk of the onset of delirium by about 91%, but melatonin has not. Next slide. And also other programs that can help is ongoing educational programs for healthcare providers, and then good pain management and avoiding sedating medications. Next slide. For post-operative delirium, when it comes to using anesthesia, it's recommended to use the lowest dose that you need. And they have considered using EEG monitor to assess the depth of dementia, but there's no sufficient evidence to say that this has been helpful yet. And adequate pain management has been shown to reduce the risk of delirium. So, giving patients regional anesthesia at the time of surgery has been shown to be successful. Avoid opioid medications if possible. Having patients take scheduled Tylenol, if they're a candidate for Tylenol, can be considered as a low pain level of pain control that's consistent. And in general, try and avoid adding sedating medications to the orders unless there is a need for it. And the purpose is to avoid unnecessary use. Next slide. So in summary, take-home messages are delirium is common. It can increase mortality and morbidity, and delirium can be prevented. So it's good to proactively think about this in whatever setting that you are practicing, and try and implement some of these actions that we can take to prevent delirium. Thank you. I think that's my slot. Yeah.
Thank you so much, Dr. Pereira. Looks like we have a question in the chat. How do you balance good pain management versus avoiding sedating opioid medications, especially if over-the-counter pain medications are not effective or potent enough?
So in general, I like to always start with Tylenol, and I encourage my patients to take scheduled Tylenol, because I do think that it's good to have a pain control to keep to prevent the pain level kind of from peaking. So I use Tylenol as a scheduled medication. I also focus on a multimodal approach to pain. So using topical medications like lidocaine patches, Voltaren gel is also used very frequently in my practice. And then, of course, if the pain is still not controlled, depending on what where the pain is coming from, you can think about like localized injections. or TENS unit. And if it doesn't work, you can think about medications like Cymbalta as part of your pain control plan. And there are times I do use opioids if I really need to.
Does anybody on the line have any comments? Or suggestions?
I think, hi, it's Valerie. I think there's another in the chat further up. I think there was another comment if you want to look at that.
Oh yeah. Jerry said olanzapine has a very high ACB, so we don't recommend using the folks with cognitive issues. That's one comment. And then Eric mentioned there may be a logical reason why an elderly 90 plus does poorly in the day of week question. Example, less variation in daily activities to help differentiate the day of the week, especially after years of COVID, therefore less need to deal with day of week information or have to figure it out, leading to forgetting. Same as asking the same elder for residence address. If the elder does not have to use that information for years because of having caretakers, for example, it can be forgotten. Thank you, Eric, for your comment.
Yeah, thank you. I agree. I think you could use an alternative method like count backwards or do a, whatever the patient that you think would be able to do.
Are there any other questions on from anyone on the line or anyone from our team? Okay. Dr. Kimbeck said, I've seen severe neurotoxicity, delirium with complex pain meds, such as Butrins, Ultram, sorry, I'm bad with pronouncing these, and these can take days to wash out, cause excess serotonin, etc.
Yeah.
Thank you for that comment. Anything else? Well, you can keep the questions coming, but while we are on the line, we'd love for you to fill out the CME forms. If you do want CME credits, you can go ahead and scan this QR code while you are on the line. And then we also